If you are over 70 and someone keeps telling you that your blood pressure must always be pushed as low as possible, this is something important to understand. For many older adults, the goal is not simply getting the number lower. The real goal is staying well, staying steady on your feet, keeping good blood flow to the brain and kidneys, and protecting quality of life. And sometimes, those things require a more careful, individualized approach than people expect. A lot of people hear one message for years: lower blood pressure is always better. And in many younger or middle-aged adults, bringing high blood pressure under control can clearly reduce long-term risk. But once people reach their mid-70s, 80s, and beyond, the conversation often becomes more nuanced. At that stage, it is not just about the reading you get while sitting calmly in a clinic chair. It is also about how your pressure behaves when you stand up, how you actually feel day to day, whether you are becoming lightheaded, and whether treatment is being tolerated well. This matters because some older adults do not have a problem only with high blood pressure. They also have a problem with pressure dropping too much when they rise from bed, stand from a chair, or get up during the night. That is called orthostatic hypotension, and it can lead to dizziness, fainting, falls, and injuries if it goes unnoticed. The usual definition is a drop of at least 20 points in systolic pressure, or at least 10 points in diastolic pressure, within a few minutes of standing. And here is where many families get confused. Someone may be told, "Your blood pressure looks great," because the seated reading is low or normal. But if that same person stands up and the pressure falls sharply, that good number may not feel so good in real life. They may notice a brief wave of weakness, a foggy feeling, or that strange moment when the room seems to shift. Those symptoms should not be brushed aside as something to simply accept. They are worth discussing. One reason this becomes more common with age is that the cardiovascular system changes. Arteries gradually become stiffer, and the body's pressure sensors do not react as quickly as they once did. Medicine handling also changes with age, because the kidneys and liver may process drugs more slowly than before. That means a treatment plan that seems reasonable on paper may hit an older body very differently than it would hit a younger one. This is why many experts now emphasize that blood pressure treatment in older adults should not be one size fits all. Frailty matters. Symptoms matter. Fall risk matters. Kidney function matters. Daily function matters. And whether a person is vigorous and active at 78 is very different from whether another person at the same age is dealing with weakness, several chronic conditions, and a history of falls. There is also something else worth knowing. Different guidelines and reviews do not all give the exact same target for older adults. Some recommend tighter control in selected patients when it is tolerated well. Others allow more moderate goals in very old adults or in people with frailty, symptoms, or standing blood pressure problems. That inconsistency itself tells you something important. The answer is not always simple, and personal context matters. So what is the practical message? The practical message is this: if you are older and being treated for blood pressure, the right number is not just the lowest number you can force. The better question is whether your pressure is controlled in a way that helps protect your heart and brain without leaving you dizzy, unsteady, overly tired, or at risk of falling. That is a much smarter way to think about it. Let me give you a simple example. Imagine two people who are both 80 years old. The first person is active, walks every day, and still feels strong overall. The second person has kidney disease, arthritis, takes several medications, and already feels unsteady getting out of bed. If both of them show the same clinic blood pressure, it does not automatically mean they should be treated in exactly the same way. One person may tolerate a lower target well. The other may need a more cautious plan because side effects and fall risk carry more weight. That is not poor medicine. That is individualized medicine. Another thing many people do not realize is that a single office reading tells only part of the story. Blood pressure changes across the day. It can be different in the morning, after meals, in the evening, during stress, and after standing. Home monitoring often gives a more realistic picture of what is happening over time than one isolated reading taken during a rushed appointment. That is why many guidelines recommend home blood pressure monitoring as part of good hypertension care. Now, one of the most useful things an older adult can do is check not only seated or resting pressure, but also what happens after standing. A practical way to screen at home is simple. Rest lying down for about 5 minutes. Take a blood pressure reading. Then stand up carefully and check again after standing. Many formal protocols measure at 1 minute and again at 3 minutes. If there is a large drop, or if standing brings on dizziness, that is information worth bringing to your clinician. It does not mean you should change your medicines on your own. It means you now have useful data for a much better conversation. That conversation becomes especially important if any of these sound familiar. You feel lightheaded when you get out of a chair. You need a moment to steady yourself after standing. You feel worse after a medication adjustment. You are unusually tired. Or you have had a recent stumble or fall for no clear reason. These are exactly the kinds of details that can change how blood pressure treatment should be approached. And this is where I want to slow down and say something clearly. The answer is not to ignore high blood pressure. Very high pressure still matters. Persistently elevated numbers can increase the risk of stroke, heart strain, kidney problems, and other complications. But in older adults, treatment should aim for balance. Too high is not good. Too low is not always better. The safest path is often the one that controls pressure while preserving stability, alertness, and everyday function. There is also evidence from older cohorts suggesting that very low systolic pressure, especially in frail older people or those on multiple blood pressure medicines, may be associated with worse outcomes in some settings. That does not prove that higher is always better. It means context matters, and aggressive lowering is not automatically the safest option for every older person. So what should someone over 70 actually do? First, do not focus only on one idealized number you heard years ago. Focus on patterns, symptoms, and how treatment feels in real life. Second, if you are on blood pressure medicine, consider keeping a home log for 1 to 2 weeks. Morning and evening readings can be helpful, especially if they are taken under similar conditions. Third, if standing up makes you dizzy, weak, or off balance, ask specifically about orthostatic blood pressure. Bring it up directly. Many people never mention it because they assume it is just age, but it may be giving your care team an important clue. Fourth, when you speak with your doctor, ask better questions. Instead of only asking, "Is my pressure low enough?" ask, "What target makes sense for my age, my health conditions, and my fall risk?" Ask, "Should we also check my standing blood pressure?" Ask, "Could any of my symptoms be related to treatment being too strong for me?" Those questions are thoughtful, practical, and absolutely appropriate. Fifth, never stop or reduce prescription medication on your own because of a video, an article, or a conversation. Blood pressure treatment should be changed carefully, especially in older adults, because the goal is steady improvement, not sudden swings in either direction. Now, if you are wondering whether there is any simple rule to remember, here is one I think is helpful. At younger ages, the main question is often, how do we lower long-term cardiovascular risk? At older ages, the question becomes, how do we lower long-term risk while also protecting day-to-day stability, brain perfusion, kidney perfusion, and independence? That shift in thinking changes everything. Because once you understand that, you stop chasing numbers blindly and you start paying attention to the whole person. And that may be the most important takeaway of all. If you are over 70, the best blood pressure plan is usually not the most aggressive one by default. It is the plan that is appropriate for your body, your symptoms, your strength, your medications, and your real life. For some people, that may mean tighter control. For others, it may mean a more moderate target and closer attention to standing blood pressure. The point is not to guess. The point is to individualize. So tonight, here is a simple next step. If you have a home monitor, take your usual reading. Then, on a separate check, test what happens after resting and standing. Write down what you feel, not just what the machine says. If you notice a meaningful drop or symptoms that concern you, bring those notes to your next appointment. Sometimes the most useful health information is not one dramatic discovery. It is one overlooked pattern that finally gets recognized. And if no one has ever explained this to you before, now you know something many people miss. In older adults, blood pressure care is not just about lowering a reading. It is about finding the range that supports both protection and stability. That is a very different goal, and for many families, it is the difference between simply treating a number and truly caring for a person. If this helped you see the issue more clearly, write the word clarity in the comments. And if you know someone over 70 who has ever felt unsteady when standing, share this with them. Sometimes one small conversation leads to one smarter question, and one smarter question can make a very meaningful difference. This video is for educational purposes only and is not medical advice. Blood pressure treatment should always be individualized with a qualified healthcare professional, especially if you have heart disease, kidney disease, diabetes, a history of stroke, falls, or episodes of dizziness. Never start, stop, or adjust medication without professional guidance.